We have another great issue this month with some really fantastic commentary by the authors of some of the trials that we are going to be discussing, as well as commentary by John and I. And we're going to start with something that is really land-breaking. A new treatment for NASH that was just recently FDA approved, and this is the New England Journal of Medicine article on a phase 3 randomized controlled trial of resmetirom in NASH with liver fibrosis. Fascinating discussion with the author. Also, a discussion with one of the authors of the article from JAMA on long-term outcomes of medical management versus bariatric surgery and type 2 diabetes. Hold on to your chairs. There's some really interesting, important results here. Then we're going to discuss an article from Diabetes Care on improved glycemic outcomes with the use of diabetes technology, independent of socioeconomic status in youth with type 1 diabetes. Then we're going to have a discussion with one of the authors of an article published in Diabetes Care titled Cardiovascular and Kidney Risks in Individuals with Type 2 Diabetes, Contemporary Understanding with a Greater Emphasis on Excess Adiposity. And finally, we're going to conclude with an article that we're going to need to think about tomorrow when we're seeing people in the office on prognostic implications of coronary artery calcium in asymptomatic individuals with prediabetes, also published in Diabetes Care. For our first article this month, we have an incredibly important article on an incredibly important topic. The topic is NASH, and the article is a phase 3 randomized controlled trial of resmetirom in NASH with liver fibrosis. Joining us to discuss this is Dr. Stephen Harrison, who is the chairman and founder for Pinnacle Clinical Research and Summit Clinical Research, as well as a visiting professor of hepatology at Oxford University. Stephen, welcome.
Yeah, thank you so much. It's great to be here. It's my honor to be here today to talk to your constituents about fatty liver, particularly about resmetirom and the recent FDA approval of this drug and the publication in New England Journal of Medicine. So thank you for having me on.
Yeah, this is an exciting time. That is the first medicine to be FDA approved for treatment. So can you, before we jump into the article, give us some background about why this is important for a group that is interested in and has lots of patients with diabetes?
Yeah, absolutely. I mean, this is the group to be talking to. Just like diabetes can be linked to retinopathy, neuropathy, and nephropathy, we know that diabetes leads to what we call a hepatopathy or fatty liver due to underlying insulin resistance. And this is a real issue. I mean, if you look at two papers I published in the past, both prospectively enrolled at Brooke Army Medical Center in San Antonio, Texas, where we look at populations of people presenting for routine colon cancer screening, and they wanted to know their liver health. We excluded anybody that had known history of liver disease, took medicines that cause fatty liver, drank alcohol that caused fatty liver, or carried a diagnosis of fatty liver. They were excluded. These are people that thought they had completely healthy, normal livers. We did MRI PDFFs. That's the gold standard for fat quantification. Identified that 38% of middle-aged Americans presenting for routine colon cancer screening had fatty liver. When we looked at the diabetics, 70% of them had fatty liver. We did liver biopsies on those people that had abnormal imaging, abnormal liver chemistry test, any reason to do a liver biopsy where we're worried about the possibility of steatohepatitis in those fatty liver patients. The prevalence in diabetics was 35%. All comers, 14%. So more than a twofold increased risk of steatohepatitis in diabetic patients. Maybe more sobering, not from my study, but from population data that's been generated 20% of those people actually have advanced liver disease. So we're talking F2, F3, or cirrhosis. So this really is the patients that we need to be drilling down on and focusing on and linking and syncing care to. So thank you for that background. That's really important.
So, critically important topic for an important group of people. Tell us a little bit about the methodology used in the study?
Yeah, so this is a quintessential phase 3 registrational trial in steatohepatitis, where there is a route to get FDA approval through an accelerated approval program, and that means you don't have to show outcomes. And diabetologists, endocrinologists, cardiologists are used to major outcome trials, these huge 10,000, 15,000 patient trials where patients are followed for years to look for outcomes. We know that for an F0 patient, a stage 0 NASH patient, to progress to decompensated disease, on average takes 20, 30 years. So we're not going to do a major outcomes trial. And the FDA realized that. And so they allowed for what we call accelerated approval. And that means we have a surrogate of something that predicts an outcome. And that surrogate is a liver biopsy that shows steatohepatitis or that shows fibrosis. And really what you're trying to show is that either you resolve steatohepatitis completely or you improve fibrosis by at least one stage. And so that's the way to get approval. You still have to go on and do the outcomes portion of the trial. That gets you full approval.
Hmm.
And we'll talk about that in the trial. But essentially, that's the methodology was to do a liver biopsy that showed moderate to advanced fibrosis in the setting of MASH or NASH. You know, we changed the nomenclature recently. And if you had that, then you could be enrolled in the trial and you were randomized equally to either 80 milligram of drug, 100 milligram of drug, or placebo, treated for 1 year, repeat liver biopsy, and looking at that dual primary endpoint of either NASH resolution without worsening of fibrosis or fibrosis improvement of at least one stage without worsening of the NAFLD activity score. So overall, 966 patients were enrolled in this subpart H approvable 1-year endpoint. Like I said, the study's ongoing. A total of 1,700 patients have actually been enrolled in the trial, and they'll march towards a 54-month repeat third liver biopsy. So they had to have a biopsy to get in. They had a biopsy at 1 year. That was the primary endpoint. We'll talk about the results of that in a moment. And then that third liver biopsy, or that second follow-up liver biopsy, if you will, at 54 months, looking at progression to cirrhosis.
Wow.
Okay, so yeah.
So it's interesting. It's not that different in a way than diabetes drugs approval, which are approved based on an A1C decrease, but then it's a part of that approval process have to have their cardiovascular outcome trials done, in that case, post-approval. So some similarity there.
Some similarities, yes.
Before we go on to talk about the results, can you tell us a little bit about what resmetirom is? Because I don't think most of our audience is familiar with it.
Absolutely. So it's very interesting. This is right up you guys' alley. This is a thyroid hormone receptor beta agonist, and it works very specifically in the liver. Importantly, it doesn't carry alpha characteristics. So if you're an alpha agonist, there's issues we know historically with cardiac tox. We don't see that here. Furthermore, this medicine doesn't get into the brain. It's not going to mess with the hypothalamic pituitary thyroid axis, okay? So this is not a hormone. This is a thyroid hormone receptor beta agonist. So it works directly in the liver. So let me tell you about why that's important. In the setting of fatty livers are relatively hypothyroid. Normally you take inactive prohormone free T4 and you convert that to T3 in the liver. That doesn't happen well. In the livers in fatty liver patients, deiodinase 1, which converts T4 to T3, is downregulated, and deiodinase 3, which converts T4 to reverse T3, is actually upregulated. So what we see in the setting of fatty liver, in fact, this is very nicely correlated. The higher the reverse T3, the worse the underlying disease activity. Okay. So what this particular drug does is it allows for normal conversion of T4 to T3 in the liver. And this works through a process where we enhance lipophagy and subsequently mitophagy to drive down reactive oxygen species, shut down the inflammation, and ultimately have a positive impact on the scar tissue that's being formed through stellate cell activation. So that's a lot of big fancy words, but the bottom line is what we do is we make mitochondrial health better in the liver,
Wow.
and you are better able to efficiently burn the fat that is in the liver. Now, it doesn't have any impact on insulin sensitivity. That's an important thing to note. But what a key secondary impact of this drug is significant lowering of LDL cholesterol, ApoB, ApoC3, lipo(a), and triglycerides.
Huh. So all these positive metabolic other effects in addition to the direct effect on the liver. Fantastic. What were the results of the trial?
Well, I'm glad you asked. So let me tell you. So the good news of great joy for all people with fatty liver is that this drug hit on both of those endpoints I alluded to. NASH resolution without worsening of fibrosis, and it hit on fibrosis improvement of at least one stage without worsening of the NAFLD activity score. It hit on both for both doses that were statistically significant. So just to give you a high-level view, for NASH resolution with no worsening of fibrosis, placebo response 9.7, 80 milligram response 25.9% of patients, and the 100 milligram dose 29.9%. Just to give you a reflection on that, the treatment effect delta, subtracting high dose from placebo, around 20% of patients had NASH resolution without worsening of fibrosis on intent to treat analysis. I want to come back to that in a minute. When we look at fibrosis improvement of at least one stage with no worsening of the NAFLD activity score, 14% for placebo, 24% for low dose, 26% for
Wow.
100 milligram high dose, treatment effect delta 12%. A key secondary endpoint at 24 weeks, not 52 for the liver biopsy, but at 24 weeks was LDL cholesterol lowering. It was 0, it was flat for placebo, down 13.6% for low dose and 16.3% for high dose. Parenthetically, that extends to about 20% improvement at 52 weeks high dose. Now, just another important point, this paper has 82 pages of supplement, by the way. So you kind of, there's a lot of juicy information in the supplement. But when people stop and think, okay, well, maybe only 2 out of 10 people had resolution of NASH and maybe 1 out of 10 for fibrosis, it's important to realize this. That was by intent to treat. If you look at people who actually took drug and had a liver biopsy at the end of treatment, it turns out that 50% of those people either had NASH resolution or fibrosis improvement, and 80% of those people had either reversal of fibrosis by one stage or they didn't progress. And we don't talk about that much, but prevention of progression of disease is actually not a bad thing either. So all in all, very positive results from an adverse event profile. I know I get asked this all the time. Yeah, but how tolerable is this drug? Is it something that can be taken for the long term? And I think it's important to note your constituents are used to using GLP-1 based therapy where they're starting low and titrating slow to try to mitigate those GI adverse events. This drug is incredibly well tolerated, incredibly safe. The over 2,000 patients were included in the safety database that was filed with the FDA. And we reported this out as EAIR. So that stands for exposure adjusted incidence rates. It may be something your constituents aren't that familiar with. So really easy to explain. If you look at 100 patient years of treatment or 100 patients treated for 1 year, how many were likely to develop an adverse event? It turns out diarrhea is the most common. And it turns out that 33% of 33 out of 100 patients at the high dose would have that side effect. For placebo, it was 14 out of 100. So it's up a little bit, but it turns out most usually occur in the first 2 to 3 weeks and then go away. It's very mild to moderate in most instances, and often it's just loose stool and not diarrhea at all. It's just they go to the bathroom more frequently. And then usually that mitigates over the first 12 weeks. Nausea was the second most common. Again, mild to moderate, occurred more common in women than men, and again, usually resolved within the first 12 weeks of treatment in most cases.
Thanks for going into that detail because we always wonder about side effects. And the level of effect is simply impressive, not just statistically significant, but this seems very much so clinically significant. And I like your point about stopping progression as an important goal for NASH. I just want to point out for our listeners that the degree of illness, if you will, or severity in the trial, 2/3 of people had diabetes approximately, but the level of AST and ALT, it was just 38 and 52 in that baseline group. In the resmetirom 80 group, roughly the same in all the groups. And the FIB-4 score was not wildly high. It was 1.4. And so if I'm understanding this correctly, this is consistent with the type of people that we might be seeing in our general practices in endocrinology practice, not just at referral centers like you're at. Is that correct?
Yeah, you're absolutely right. You're absolutely right. 50% of the people in this trial with F2, F3 disease had FIB-4 scores that were below the cutoff that we usually describe in the ACE guidance or even the liver guidance that have been published. So it's important to just think about a diabetic being a diabetic, right? So diabetics, the data are 70 to 80% have fatty liver, 35 to 40% have NASH, and about 20% of them actually have advanced liver disease. So if you put that in perspective, 2 out of every 10 diabetic patient walking through your door would be a resmetirom treatment candidate.
Wow.
Just by looking at them, at face value.
Pretty amazing. We just have a short time left. So what do you feel are the take-home points for our audience here?
I think the take-home points are really just that we have had a seismic shift in the management of patients with metabolic associated steatohepatitis. First drug approval. I've been studying this drug I've been studying NASH since the turn of the century. And I spent my career studying this disease, and to be able to say that we now have something to offer our patients is incredible. Do we have work to do? Yes. Can we improve on this? Absolutely, we can. But now we have something to treat with. I know many of my constituents on the GI side would say, Doc, I'll start looking for these patients when you give me a treatment for my patients.
Mm-hmm.
Well, now we have a treatment. So
Wow.
now we need to do a better job of identifying these patients and getting them worked up, identifying the risk. And if they're in the treatable category, we need to use liver-directed therapy, not just GLP-1 based therapy. Because remember, with GLP-1s, no data on fibrosis improvement. And fibrosis is what portends a worse prognosis.
Fantastic. Really exciting information. Dr. Stephen Harrison, thank you so much for going over this article with us.
Hey, thanks so much for having me today. Have me back anytime.
Our next article is one that I think is going to really make us think. This was published in JAMA. The title is Long-Term Outcomes of Medical Management versus Bariatric Surgery in Type 2 Diabetes. And joining us to discuss this article is one of the authors, Mary Elizabeth Patti, who is a physician scientist at Joslin Diabetes Center. She is an adult endocrinologist. She's director of the Hypoglycemia Clinic and associate professor of medicine at Harvard Medical School. Mary Elizabeth, thanks so much for joining us.
My pleasure.
Can you start by telling us the background to this article? Why did you all decide to do this deep dive and look at this question?
Well, there's increasing evidence that's accumulated over the past few decades that metabolic or bariatric surgery is a highly effective therapy for type 2 diabetes. However, the studies that have been performed to date were either non-randomized, for example, the long-term Swedish obesity study, or small randomized trials. So to really define whether bariatric surgery was superior to medical management of type 2 diabetes, we understood that a larger randomized trial comparing surgery with medical management was required. And so at the beginning of this study, there were 4 independent groups who had performed randomized trials of surgery versus medical management. But we realized that really to get a robust, effective conclusion, we needed to merge these trials for long-term follow-up of the participants who had been randomized to either medical management or for surgery for type 2 diabetes. And that was really how the ARMS T2D study came into being.
Fantastic. And can you tell us a little bit about the population, the amount of time over which the two groups were compared?
Yes. So the patients that were enrolled into this study were fairly typical patients with type 2 diabetes, complicated also by obesity. And if we look at the baseline characteristics of our study participants, they were middle-aged individuals. There was a higher proportion of women, which is consistent with other studies that have been performed as well. And these individuals were, they didn't have well-controlled diabetes at study entry. In fact, the mean hemoglobin A1C in the surgical group was 8.7 and 8.2 in those randomized to medical management. So these are not well-controlled patients to begin with. They had diabetes for an average of 7 to 8 years, and almost between 40 and 50% of them were on insulin at the time of randomization to the intervention arms. Also, they had obesity with a mean body mass index of 36 to 37. So I think these are fairly typical patients that we would experience in a clinical population with type 2 diabetes. And I think that enhances the generalizability of our results.
That's helpful to understand that. And what were the results?
Well, the results were that those individuals who were randomized to surgery had a marked improvement in diabetes and weight-related outcomes. The primary outcome was assessed at 7 years after randomization and implementation of the treatment group, either medical therapy versus surgical intervention. But some of the individuals were followed, and we reported data up to 12 years of follow-up but the primary outcome was at 7 years. And at 7 years, there was a much greater reduction in hemoglobin A1C with surgery. In the medically treated group, despite our best efforts, hemoglobin A1C was 0.2% lower than at study entry, whereas those who were randomized to surgery had a drop in hemoglobin A1C of 1.6%.
Wow.
And these impressive differences were maintained at the 12-year follow-up for those patients where, who were followed for up to 12 years. So really impressive improvement in hemoglobin A1C with surgery. And also, if you think about diabetes care, we want to improve control, of course, but an emerging target is, can we induce remission of diabetes? And so in this regard, our study also revealed that remission, meaning hemoglobin A1C less than 6.5 without any diabetes medications, was also about threefold higher in the surgically treated individuals. So at 7 years, 18% of people in the surgical group achieved diabetes remission as compared to only 6% in the medically treated group. So this is very impressive because remission off of all diabetes medications is obviously very challenging. And even at 12 years of follow-up, 12% of patients in the surgical group still experienced remission. And why is this so important? Because every year of remission has been shown to reduce the risk of complications by as much as 19%.
Mm.
So we know that diabetes is a progressive disease, but if we can induce and maintain remission, that's certainly an important goal.
It is, and these are impressive results. The obviously bariatric surgery also had sustained changes in weight, I assume.
Yes. So at 7 years, the people who had been randomized to bariatric metabolic surgery lost about 20% of their body weight as compared with 8% in the medical group. And these differences were really maintained at the 12-year time point as well. And so I think this is quite impressive, durable weight loss in the surgical group, despite the fact that in the medically treated group, you know, a substantial number of patients were also treated with GLP-1 receptor agonists.
And when you mention GLP-1 agonists, I always think about GI side effects on the medicine side. Were there any side effects of note that are worth talking about in terms of bariatric surgery?
Well, of course, there are complications of any approach to diabetes care, whether medications or surgical approaches. In the analysis, anemia, fractures, and gastrointestinal side effects were more common after bariatric surgery. Not surprisingly, given concern, you know, side effects of malabsorption, iron deficiency, vitamin D deficiency, calcium deficiency that can occur as a result of malabsorption after surgery. And I think these underscore that the benefits of bariatric surgery are very striking, but it's very important that these individuals who receive this therapy be followed up in the long run to be sure that they continue to be assessed for vitamin and micronutrient supplementation, and to you know, realize that this is something that does require lifelong monitoring. So it's not a simple one and done procedure. It does require lifelong attention, attention to nutrition, and follow up by their care team, their medical care team.
Yeah, I'm so important. So glad that you pointed that out, because a lot of people do think of, you know, you get the procedure once and it's not set it and forget it. It's, you know, all of our approaches require ongoing care. This is one of those studies that really makes me think a lot. I'm interested what you see as the clinical implications. How does this affect your adult endocrine practice when you're advising patients?
Well, I think we have to look at the data carefully. And the data really demonstrate the sustained benefits of metabolic surgery. And even in individuals who had a BMI of less than 35 at study entry, the benefits are clear. It's not only for patients who have even higher BMIs. So there are many benefits of bariatric metabolic surgery, changes in incretin hormones that are that result from the surgery itself. So when we think about this in the clinical practice, I think we need to offer metabolic surgery as an option to our patients. And, it's a very individual decision for a patient. Some patients will say, I would never have surgery. But if we show them the data and say, look, this is an option for long-term control, that long-term glycemic control, long-term maintenance of weight loss, sometimes without a need for diabetes medications. This may be something that patients want to think about and make, after careful consideration, may elect to have surgery. And so I think as endocrinologists or internists or family physicians, we need to present the data to patients and allow them to make a decision along with their care team. And we can't put our heads in the sand that we need to think about surgery as a primary therapy for sustained management of type 2 diabetes. Yeah, it's not for everyone. Admittedly, there are side effects just like for any therapy.
Do you have any thoughts about when, during the course of someone's care with diabetes, you would recommend bariatric surgery or begin to bring it up? Because when I look at the group that's included here, this is a group that is probably a little tougher to control. It's not the group that's easily controlled on metformin alone. Half the people had insulin, but it's also not a group that's wildly out of control either. When in the course of someone's care do you feel it's helpful to bring up bariatric surgery as an option?
I think it's important to introduce the concept that diabetes remission can be achieved with substantial interventions. And so maybe not on the first visit, but as you're developing a relationship with the patient and talking about long-term goals of diabetes therapy, we should be talking about ways to reduce complications, ways to prolong life, and reduce obesity-related complications as well. And so as part of that discussion, I would say it should be implemented quite early after diagnosis. Put it on the radar screen and don't wait until 5 years have elapsed. You'll get more bang for the buck if bariatric metabolic surgery is implemented early in the course of diabetes, which we know is a progressive disease. So earlier is better. Don't wait until diabetes control has failed.
This is so helpful to hear your perspective, Mary Elizabeth Patti. Thank you so much for sharing both the data and your perspective on how to integrate this clinically.
My pleasure. Thank you very much.
For our next article, we're going to be discussing an article from Diabetes Care titled Improved Glycemic Outcomes with Diabetes Technology Use, Independent of Socioeconomic Status in Youth with Type 1 Diabetes. The goals of the authors were to look at technology use in type 1 diabetes and how it's impacted by socioeconomic status. The analysis explored the relationship between socioeconomic status, glycemic control, and technology use, and they did this by looking at a cross-sectional analysis of A1C. They looked at data from over 2,800 Australian youth with type 1 diabetes. They looked at residential postal codes in order to assign a socioeconomic based status on the index called the Index of Relative Socioeconomic Disadvantage, the IRSD. Then they looked at a linear regression model in order to evaluate the associations between IRSD quintile, A1C outcomes, and the management regimen that was used. Insulin pump therapy, CGM, and their concurrent use were all associated with lower mean A1Cs across all IRSD quartiles. There was no interaction between technology use and IRSD quartile on the effect on A1C, reflecting similar associations of lower A1C with technology use across all zip codes. John?
So, Neil, I think a very interesting thing. I think one of the things kind of interesting talking about new technology, whereas the insulin pump is actually older than me, discovered in 1963, started out as a backpack, and then about 10 years later, it became an implantable thing. So certainly not new technology. So I think the interesting points of this article is regardless of what your a priori economic status, you're going to have about the same A1C impact if you're using technology, and that was across all of the different quintiles that they looked at for economics. But sadly, we are not equally using technology across these groups. So even if you look at places like Canada that has a national healthcare system, there are huge differences that are seen in the people who are in the lowest economic group with regard to whether they're using these technologies, and that has bore itself out in other countries as well. So I think that when we are thinking about using technologies, we need to have equity. So this needs to apply, and this is type 1 diabetic children. We need to have this accessible to every child with diabetes, and socioeconomic status should not be a barrier or a reason not to add on this technology to this young person's care.
For our next article, we're going to cover an article from Diabetes Care titled Cardiovascular and Kidney Risks in Individuals with Type 2 Diabetes, a contemporary understanding with greater emphasis on excess adiposity. And joining us to discuss this article is one of the authors, Dr. Darren McGuire, who is the Distinguished Teaching Professor, Jerry H. Mitchell, MD, Distinguished Chair in Cardiovascular Science at the UT Southwestern Medical Center. Darren, welcome back.
Thanks, Neil. Always good to be with you.
It's always a pleasure, and this is such an important article for our listeners to understand the concepts you discuss. Can you share some background about why you and the other authors undertook the very large endeavor of writing this article?
Right. It's a review article that kind of takes some work that we've done together with Naveed Sattar, especially, and I have collaborated on several projects. We've had the privilege of working with the National Diabetes Registry in Sweden, where we've had some seminal papers publishing the epidemiology of cardiovascular and kidney risk associated with diabetes, both type 1 and type 2. And then we went through the experience of the SGLT2 inhibitors and trying to unravel kind of the mechanistic underpinnings of how they may be favorably affecting cardiovascular disease, and came to the realization that we'd had a really myopic view of the cardiovascular complications of diabetes for focusing mostly on atherosclerosis and atherosclerotic cardiovascular disease. What was left behind in all that conversation, but really has come to the forefront now, is heart failure and chronic kidney disease. And those are two particularly important comorbidities when we're talking about obesity per se or excess adiposity, independent of diabetes status and also independent of the presence of ASCVD. So we're kind of turning the table a bit, bringing in heart failure and CKD. The American Heart Association, as you know, has recently launched this concept of a new syndrome, cardiokidney metabolic syndrome, and really putting all these together and the true underpinning of all of that excess adiposity.
I love the term you use, Darren, a myopic view, because it really describes so well. We don't see things that might be in front of us when we don't have the vision to look or the ability to see them. Can you talk about some of the evidence, lines of evidence that you discuss in the article linking adiposity and the outcomes that you talked about.
Yeah, and we'll tap into actually data that came out after we had curated the paper, largely the data from the SELECT trial. It pretty much is in lockstep with what we focused on in this paper, in this review paper. We didn't know the data, but we anticipated. Of course, the SELECT trial showed that the obesity dose of semaglutide, the 2.4 milligram weekly dose, favorably affected atherosclerotic cardiovascular outcomes in people with obesity but without diabetes, but who had prevalent ASCVD at study entry. Now, what we anticipated in that is not, we weren't certain we would see this atherosclerosis benefit, but sure enough, it was there. But what we were really anticipating is the effect on heart failure, which was proven in the SELECT trial, the reduction in incident hospitalization for heart failure, and also slowing of kidney disease progression. I think it's the very last analysis in the table 2 of the paper, but the composite of kidney disease outcomes was also favorably affected, statistically significantly affected in SELECT with semaglutide. So I'm very excited to see the secondary publications from that study drilling down on the heart failure signal and also on the kidney disease signal, and that will really nicely buttress what we've spoken about in this review article.
Yeah, I guess so will the to be published flow trial. We would anticipate that that will further support this.
Yeah,
Is
and
that
what I
right?
think, good point. So as you know, and maybe the listeners do as well, but the FLOW trial is a large-scale randomized clinical outcomes trial of people with type 2 diabetes and chronic kidney disease randomized to semaglutide versus placebo. And as was announced in the press, this was stopped early for efficacy. Now, when you stop a study early for efficacy that has a primary kidney composite outcome, that's almost always driven by change in GFR. And I don't think a wise IDMC would stop a trial because the eGFR's progression has slowed. I think what we are going to see, I will not be surprised if there's a mortality benefit.
Wow.
There has to be a major clinical outcome that was favorably affected to stop a trial early for efficacy. So I will not be surprised. Not only does kidney disease progression get slowed down, but also my guess is there will also be a favorable mortality effect. So that's again expanding the GLP-1 receptor agonist efficacy from heart failure and from ASCVD and now into chronic kidney disease.
Fascinating. Can you talk a little more about the SGLT2 story?
Yeah, and you know, we saw this these signals very early on in the development of the drugs once we started doing the larger trail outcomes trials where ASCVD was favorably affected, but the real wow factor with these SGLT2 inhibitors are the reduction in heart failure. It's a class effect. Every single one has almost exactly the same beneficial effect on heart failure outcomes, while the atherosclerotic-based outcomes differ a little bit trial to trial and drug to drug. The heart failure and the kidney disease favorable effects are all spot on, almost exactly the same. We published a meta-analysis showing that the heterogeneity between the trials is the I-squared value is 0, which means every little bit of difference in the outcome in the trials can be explained by chance alone. You almost never get that degree of homogeneity across trials when you do meta-analyses.
Now, can I go back to the title of the article? And that was a contemporary understanding with greater emphasis on excess adiposity. We are familiar with the effect of SGLT2s on heart failure and kidney disease. We're familiar, you just went over the effect of GLP-1s on heart failure, atherosclerosis, and kidney disease. Can you talk a little bit more about the adiposity piece?
Yeah, we wanted to really focus the upstream risk of adiposity, excess body weight. We tend to think about it a lot more once comorbidities begin to accrue. So we get type 2 diabetes or even impaired fasting glucose, atherosclerosis, heart failure. So that is when the patients truly get onto the clinical radar screen. But this adiposity has been going on many times for decades and whittling away, incrementing the risk on a daily basis for decades. You know, the excess adiposity gets deposited in organs. It's in the pancreatic beta cells. It's in the myocardium. Of course, we know it's in the metabolic associated fatty liver disease. It gets into the skeletal muscle and worsens insulin sensitivity. So it's the adiposity that's underpinning all of these subsequent cardiometabolic and kidney complications. So, you know, we're not there yet. We've just shown in people with atherosclerosis, this drug is effective. I fully anticipate we will go next into the impaired fasting glucose patients with impaired fasting glucose, people before they have atherosclerotic cardiovascular disease. But now we're talking about 40% of the US population. And we haven't talked about the cost of these drugs. I don't know if you've heard the news, but Medicare decided yesterday they're going to fund Wegovy for weight loss in the Medicare population for people with atherosclerosis. So, we've been wrestling with Medicare to get the SGLT2 inhibitors and the GLP-1 receptor agonists funded just for the people with diabetes who have indication. But now you're backing this up into the patients with obesity. That's 7 or 8 million US citizens that will qualify for it.
That is really good news.
So I think it's fantastic. I totally agree.
Yeah.
And I hope the third-party payers will follow suit. And
I think the SELECT trial, I mean, the hard endpoints there are hard to argue with. I mean, it is one thing, and we're not going to talk about all the issues of, funding for 42% of the population. But when you talk about people who have existing coronary disease and the endpoints that we saw in the SELECT trial, I'm really happy that insurance is paying attention. I was particularly struck by your discussion of younger adults with younger onset diabetes secondary to adiposity, and how that had almost a compounding effect. You put a little bit of money in the bank and you wait a long time, you have a lot of money. It's the opposite awful compounding effect here. You put some adiposity in a person at a young age, and you just went over so nicely in the article how that has negative effects that accrue over time. Can you say a word or two about that?
Yeah, it's a great point, and one that doesn't get emphasized enough. It's not just, we see the Kaplan-Meier curves and we look at the end of them and look at the absolute risk difference that's accumulated over time. But what we're not so commonly paying attention to is the time that develops. We're not just increasing absolute risk vertically, we're reducing a healthy lifespan, right, by confounding health with obesity and adiposity. And so, these people have shorter lifespans, they have more morbid lifespans, and and it can happen as early as children. I remember the time around 2005 or 6 when the realization in Texas is that we had more adolescents with type 2 diabetes than we had with type 1. So,
Wow.
we've got a whole lifetime of morbidity that's driven by this adiposity that we have to get around. And it's not going to be, lifestyle always plays a role here, behavioral education, but at the end of the day, we're just losing that battle completely. And it's wonderful to have therapeutics available. It will be even more wonderful once they become generic and even more broadly affordable, like we experienced with the statins over time. We were a little stingy with the statins early on because they were so very expensive and we had to have adequate numbers needed to treat for efficacy. But then as the statins became generic, we're now, pretty much 70% of the US adult population has some indication to consider a statin.
Pretty amazing. We're about out of time. Critically important information for clinicians to understand. Do you have any take-home messages about clinical implications of this?
The take-home message I would give as a cardiologist, I've been really focusing over the last 5 to 7 years on encouraging my cardiology colleagues to embrace the SGLT2 inhibitors and the GLP-1 receptor agonists for their cardiovascular benefit. It's not that we're treating hyperglycemia, and now that we've extended the observations of efficacy down into people without diabetes, it even underscores even further the importance for cardiologists and primary practitioners to embrace these drugs. These aren't for endocrinologists to prescribe anymore, and we're going to have to figure out, once we can get patients funded or have access to the medications, it's our job to prescribe them.
That's fantastic. I really think it's going to encourage a lot of working together between primary care and cardiology. Dr. Darren McGuire, thank you so much for joining us.
All right. Thanks, Neil.
Our next article is from Diabetes Care. It looked at epidemiology and prognostic implications of coronary artery calcium in asymptomatic individuals with prediabetes, a multi-cohort study. So this study pulled participants free of clinical atherosclerosis from 4 prospective cohorts: the multi-ethnic study of atherosclerosis, the Heim-Nixdorf recall study, the Framingham Heart Study, and Jackson Heart Study. 2 definitions were used for prediabetes: a fasting blood glucose greater than or equal to 100 but less than 126, and an A1C greater than or equal to 5.7 and not greater than 6.5. The study included close to 14,000 participants whose mean age was 58 years of age. 54% were women, 57% were white, 27% were Black. The proportions who had a coronary artery calcium score greater than or equal to 100 were 17, 22, and 37 in those with euglycemia, prediabetes, and diabetes, respectively. Over a median follow-up time of 14.6 years, individuals with prediabetes and a coronary artery calcium score of greater than or equal to 100 had a higher unadjusted 10-year incidence of atherosclerosis, 13.4%, than the overall group of those with diabetes, 10.6. In adjustment analysis using the inclusive definition of prediabetes compared to euglycemia, the hazard ratio for atherosclerosis were 0.75 for prediabetes and a calcium score of 0, 0.7 for prediabetes and a calcium score of 1 to 99, 1.54 for prediabetes and a coronary artery calcium score of greater than or equal to 100, and 1.64 for the patients who had diabetes. Neil?
John, I really appreciate this article because we're ordering calcium scores more and more often now as a way of risk stratifying among our patients, figuring out both whether or not to use a statin is the most common reason, but also what kind of lipid goals should we be shooting for. And this is really helpful. You know, if we look at the patients here with prediabetes, half of them had a calcium score of 0. That means their likelihood of having an event, and as shown in this study, is very low, much lower than the average person without prediabetes, with euglycemia. Yet 20% of the group with prediabetes had a calcium score greater than 100, and this study really nicely informs us that our lipid goals, for instance, here shouldn't be the usual goals. Remember, this year's standards of care says the lipid goal, the LDL goal for people with diabetes is less than 70. Well, given that a calcium score greater than 100 in someone with prediabetes, and remember, prediabetes is very common. Almost a third of the population has prediabetes. A calcium score greater than 100 with prediabetes gives you a diabetes equivalent risk of developing an atherosclerotic event. We ought to be shooting for low lipid levels in this group. So this also reminds me of an article that came out just about 6 months ago, and I'll share it because I found it very useful in the office. And this was an article by Matt Budoff in JACC Cardiovascular Imaging, not something we usually read. It was published in September, and here they looked at an enormous cohort of individuals and found that for people, and this was all comers, for people with a calcium score greater than 300, there was a 12-year event rate that was equivalent to that which someone had who had established coronary disease. You know, we've known for a long time that calcium score of 0 in our average person means we might not have to treat them with the statin, but then often we don't know what to do when we get back these higher calcium scores. That article, this article we discussed today, calcium scores above 300 in that article showed an ASCVD equivalent risk. This article is showing a calcium score in someone with prediabetes that is above 100, gives us the equivalent risk of someone with diabetes. This completes in many ways our knowledge of what to do when we order these tests. For more information and links to the articles that we discussed in this issue, just go to www.diabetesjournals.org. Until next week, keep listening
And keep learning.